Welcome to Total Hip Arthroplasty, Evidence-Based Update, a continuing education course designed for physical therapists, occupational therapists, nurses, and allied health professionals. This is an advanced level course in the clinical domain of orthopedics and geriatrics. Total hip arthroplasty remains one of the most frequently performed and clinically successful surgical procedures in orthopedic practice, with over 450,000 primary THAs performed annually in the United States alone. And over the past decade, the perioperative and rehabilitative picture surrounding THA has changed substantially. That's been driven by the widespread adoption of enhanced recovery after surgery protocols, evolving evidence on postoperative movement restrictions, advances in pharmacological thromboprophylaxis, and the emergence of telerehabilitation as a viable care delivery model. These changes demand that rehabilitation and healthcare professionals stay current with evidence-based knowledge to optimize patient outcomes across the continuum of care. This course provides an advanced-level, thorough update on the evidence base guiding total hip arthroplasty rehabilitation for interprofessional healthcare teams. We'll synthesize the most recent systematic reviews, meta-analysis, randomized controlled trials, and clinical practice guidelines published between 2022 and 2025, supplemented by foundational landmark studies that continue to shape how we practice today. The content follows the patient journey from pre-operative optimization through long-term functional recovery. Module 1 examines prehabilitation strategies and comorbidity management, including perioperative glycemic control. Module 2 addresses enhanced recovery after surgery protocols, multimodal analgesia, venous thromboembolism prophylaxis, and wound care. Module 3 explores the shifts in early mobilization, weight bearing, and the evolution away from routine hip precautions. Module 4 provides a framework for rehabilitation pathway selection, risk stratification using validated tools, and discharge planning. Module 5 details phase-specific exercise programming, progressive resistance training, and balance and proprioception rehabilitation. Module 6 covers interdisciplinary care models, telerehabilitation evidence and patient selection, and emerging technologies including artificial intelligence applications. Module 7 addresses special populations, including trauma patients and those with cognitive impairment, as well as return to activity milestones. The course wraps up with detailed case studies that integrate principles from all preceding modules into realistic clinical scenarios. Throughout this course, specific effect sizes, confidence intervals, odds ratios, and sample sizes are reported so you can critically appraise the strength of evidence behind each recommendation. This evidence-based approach ensures that you can translate current research into individualized, patient-centered care decisions that optimize outcomes following total hip arthroplasty. The course concludes with 4 detailed, interdisciplinary case studies that challenge you to integrate knowledge from all preceding modules into realistic clinical scenarios spanning low-risk elective patients, complex comorbidity management, trauma populations with cognitive impairment, and telerehabilitation implementation in underserved settings. Upon completion of this continuing education course, you'll be able to achieve the following measurable objectives. First, you'll be able to identify evidence-based prehabilitation strategies that reduce early postoperative complications following total hip arthroplasty. Second, you'll be able to describe the key components of enhanced recovery after surgery protocols for perioperative management of total hip arthroplasty. Third, you'll be able to compare pharmacological venous thromboembolism prophylaxis options based on patient risk stratification after total hip arthroplasty. Fourth, you'll be able to differentiate between patients who require formal, supervised rehabilitation and those appropriate for self-directed recovery using validated screening tools. Fifth, you'll be able to explain phase-specific exercise progression and progressive resistance training protocols across the continuum of total hip arthroplasty rehabilitation. Sixth, you'll be able to recognize clinical scenarios to determine appropriate telerehabilitation candidacy and discharge disposition following total hip arthroplasty. Seventh, you'll be able to distinguish rehabilitation considerations for special populations, including trauma patients and those with cognitive impairment, from standard elective total hip arthroplasty recovery pathways. Let's begin Module 1, which addresses preoperative optimization, prehabilitation, and comorbidity management. We'll start with the evidence for structured prehabilitation. Structured prehabilitation before primary total hip arthroplasty has emerged as a meaningful component of the perioperative pathway, though the durability of its benefits remains a subject of ongoing investigation. The most thorough recent synthesis, an overview of systematic reviews and meta-analysis by Keogh and colleagues published in 2025, pulled together data from 19,000 phase-specific randomized controlled trials involving 1,110 patients. It showed that prehabilitation programs incorporating resistance training produce measurable improvements in postoperative complication rates, muscular strength, objective function, quality of life, and self-reported functional outcomes. But here's the critical finding. These benefits are most pronounced within the first 6 months following surgery, with progressive attenuation after that. That temporal pattern has significant clinical implications for how we position prehabilitation within patient expectations and rehabilitation planning. Punus and colleagues in 2023 provided additional detail through a systematic review and meta-analysis of 48 randomized controlled trials encompassing 3,570 participants across orthopedic surgical populations. Their analysis reported moderate certainty evidence that prehabilitation improves preoperative health-related quality of life in THA candidates. Specifically, the weighted mean difference on the SF-36 was 7.35 points, with a 95% confidence interval of 3.15 to 11.54. They also found improved muscle strength in hip abduction, with a standardized mean difference, or SMD, of 1.03. An SMD lets us compare results across studies that use different measurement tools. Think of it as a common yardstick. Generally, 0.2 is a small effect, 0.5 is moderate, and 0.8 or above is large. So an SMD of 1.03 is a large effect. The 95% confidence interval for that was 0.03 to 2.02. That means if we repeated this study 100 times, we'd expect the true result to fall within that range 95 times out of 100. The improvement in abduction strength is particularly relevant given the well-established relationship between hip abductor weakness and postoperative gait dysfunction, balance impairment, and fall risk. Now, the question of which prehabilitation components deliver the greatest benefit was addressed by M. Syak and colleagues in 2025 in a landmark network meta-analysis of 186 randomized controlled trials with 15,684 participants, making it the largest such analysis in the prehabilitation literature to date. Exercise emerged as the single most effective individual component for reducing postoperative complications, with an odds ratio of 0.50, confidence interval 0.39 to 0.64. Nutritional optimization came in second, with an odds ratio of 0.62, confidence interval 0.50 to 0.77. What's really interesting is that combined interventions integrating exercise, nutrition, and psychosocial support produce the broadest improvements, with a mean difference of 3.48 points on the SF-36 physical component summary, confidence interval 0.82 to 6.14, and a 43.43 meter improvement in 6-minute walk test distance, confidence interval 5.96 to 80.91. These findings point to multi-component prehabilitation programs addressing physical, nutritional, and psychological domains as offering the strongest preparation for surgery. Technology-assisted prehabilitation has expanded access to preoperative preparation, particularly for patients in rural or underserved areas. Guida and colleagues in 2024, in a systematic review and meta-analysis of advanced technology platforms including telehealth-delivered prehabilitation, reported improvements in the WOMAC function subscale both before surgery, with a mean difference of negative 7.45, confidence interval negative 10.71 to negative 4.19, and after surgery with a mean difference of negative 7.84, confidence interval negative 11.80 to negative 3.88. Those are clinically meaningful effect sizes, and they suggest that technology-delivered programs may achieve comparable outcomes to in-person prehabilitation, broadening the reach of preoperative optimization. Despite the promise of prehabilitation, the evidence base isn't without limitations. Svinenoy and colleagues in 2025 conducted a rigorously designed, randomized controlled trial specifically targeting patients aged 70 years and older, a population with the greatest theoretical benefit from preoperative optimization. Their 6 to 12 week prehabilitation program improved preoperative gait speed by 0.15 meters per second, confidence interval 0.02 to 0.28, and hip disability and osteoarthritis outcome score, or HOOS, quality of life scores by 11.93 points, confidence interval 3.38 to 20.48, immediately before surgery. But it didn't yield significant postoperative differences compared to usual care at 3, 6, or 12 months post-surgery. This highlights a recurring theme. Prehabilitation may improve the patient's condition at the time of surgery without necessarily altering the long-term postoperative trajectory. Current clinical practice guidelines reflect the uncertain evidence base with divergent recommendations. The American Academy of Orthopaedic Surgeons, or AAOS, 2024 guideline recommends preoperative rehabilitation, albeit acknowledging limited overall strength of evidence. The NICE guidelines don't recommend preoperative rehabilitation universally. And the Royal Dutch Society for Physical Therapy guidelines recommend prehabilitation only for patients who have an increased risk of delayed recovery. So clinicians should consider prehabilitation, particularly exercise and nutritional optimization, as part of a thorough perioperative strategy for higher-risk patients, recognizing that its benefits are most evident in the early postoperative period and should be framed accordingly in patient education. Additional evidence on the timing of preoperative optimization and pain outcomes was synthesized by Hayashi and colleagues in 2023 in a detailed systematic review examining postoperative pain trajectories in patients receiving preoperative exercise. The analysis demonstrated moderate reductions in postoperative pain during the immediate recovery window, with standardized mean differences of negative 0.34 at less than 2 months and negative 0.41 at 3 to 5 months. Those represent clinically meaningful pain reduction during the phases when pain is most disruptive to rehabilitation participation. These pain reduction benefits don't persist beyond 6 months, suggesting that preoperative exercise confers an early recovery advantage that may help patients engage in postoperative rehabilitation during the critical early window. This temporal pattern helps explain why prehabilitation shows observable benefits during early recovery, even when long-term functional outcomes eventually equalize between prehabilitation and non-prehabilitation groups. So what does all of this mean in practice? For low-risk, highly functional elective patients without significant comorbidities who are scheduled with adequate time for prehabilitation, typically at least 4 to 6 weeks prior to surgery, prehabilitation focusing on resistance training and nutritional optimization represents a reasonable component of thorough perioperative care. On the other hand, for patients with recent surgical scheduling of less than 2 to 3 weeks, advanced age coupled with severe frailty, or complex psychosocial barriers to program adherence, clinicians shouldn't delay necessary surgery to implement prehabilitation. The evidence supports a selective, individualized approach rather than universal prehabilitation mandates, with priority given to higher-risk patients who have adequate time for program engagement and demonstrated motivation. Let's turn now to nutritional optimization and protein supplementation, which represents the second most effective individual prehabilitation component after exercise, with that odds ratio of 0.62 for postoperative complication reduction. Protein supplementation is central to nutritional prehabilitation, as surgical stress increases protein requirements to 1.2 to 1.5 grams per kilogram body weight per day, substantially exceeding usual dietary intake in many older adults. Preoperative protein supplementation for 2 to 4 weeks prior to surgery has been associated with reduced postoperative nitrogen loss, improved wound healing trajectories, and decreased infection rates. Specific nutritional targets include correction of preoperative anemia, defined as hemoglobin less than 13 grams per deciliter in males and less than 12 grams per deciliter in females, through iron supplementation or erythropoietin-stimulating agents when indicated. Vitamin D repletion to levels above 30 nanograms per milliliter, with supplementation of 2,000 to 4,000 international units daily for deficient patients, is also recommended. Albumin optimization above 3.5 grams per deciliter serves as a marker of overall nutritional status. And here's why that matters. Preoperative albumin below 3.5 grams per deciliter is independently associated with increased surgical site infection risk, with an odds ratio of 2.1, confidence interval 1.4 to 3.2, prolonged hospital stay, and higher 30-day readmission rates. Immunonutrition formulas containing arginine, omega-3 fatty acids, and nucleotides administered for 5 to 7 days preoperatively have shown promise in reducing infectious complications in high-risk surgical populations, though THA-specific evidence remains limited. Clinicians should screen all prehabilitation candidates for nutritional risk using validated tools such as the Malnutrition Universal Screening Tool, known as MUST, and refer patients identified as medium or high risk to a dietitian for individualized intervention. Smoking cessation and alcohol reduction represent additional modifiable preoperative risk factors with strong evidence supporting intervention. Current smoking is associated with a 2.0 to 2.5 fold increased risk of surgical site infection, delayed wound healing, and periprosthetic joint infection following THA. Smoking cessation initiated at least 4 weeks preoperatively reduces wound complication rates to levels approaching those of non-smokers, while cessation within 2 weeks of surgery may paradoxically increase pulmonary complications due to increased mucus production during the initial cessation period. Similarly, alcohol consumption exceeding 14 standard drinks per week is associated with increased perioperative bleeding risk, impaired wound healing, and higher infection rates. Structured preoperative cessation programs combining pharmacotherapy, such as nicotine replacement therapy or varenicline for smoking and naltrexone, or acamprosate for alcohol use disorder, with behavioral counseling achieve cessation rates of 40 to 60% at 4 weeks, substantially improving the perioperative risk profile. These modifiable risk factors should be addressed during the prehabilitation window, with referral to appropriate cessation services integrated into the preoperative optimization pathway. Let's now look at perioperative comorbidity management, focusing on diabetes and glycemic control. Diabetes mellitus represents one of the most prevalent and clinically significant comorbidities in the THA population, affecting perioperative risk, rehabilitation progression, and long-term outcomes. The American Diabetes Association 2026 Standards of Care recommend a preoperative hemoglobin A1C or HbA1c threshold of 8% or below within 3 months of elective surgery, with target perioperative blood glucose maintained between 180 milligrams per deciliter. Insulin therapy should be initiated for fasting glucose levels at or above 140 milligrams per deciliter or postprandial glucose at or above 180 milligrams per deciliter. Rox and colleagues in 2024 provided more granular THA-specific data, identifying that a preoperative HbA1c at or below 7% minimized the risk of postoperative glucose exceeding 190 milligrams per deciliter, a threshold associated with increased surgical site infection and delayed wound healing. The perioperative management of diabetic medications requires careful coordination. Kumar and colleagues in 2025 published detailed guidelines recommending that metformin be held on the day of surgery, that SGLT2 inhibitors be discontinued 3 to 4 days preoperatively to prevent euglycemic diabetic ketoacidosis, which is a rare but potentially life-threatening complication, and that oral hypoglycemic agents be resumed when the patient is eating and drinking well postoperatively. For insulin-dependent patients, basal bolus regimens are preferred over correction-only approaches during the perioperative period, as they provide more consistent glycemic control and reduce glucose variability. Here's what I find encouraging. Well-controlled diabetes doesn't preclude participation in accelerated recovery pathways. While insulin-treated diabetes is associated with increased odds of length of stay exceeding 4 days, with an odds ratio of 2.2 and diabetes-related morbidity with an odds ratio of 2.3, there's no increase in periprosthetic joint infection or mortality in fast-track settings when glycemic control is maintained. That tells us that thorough perioperative glucose management protocols, including preoperative optimization, perioperative monitoring every 4 to 6 hours, standardized insulin protocols for inpatients, clear medication management plans at discharge, and early postoperative follow-up enable diabetic patients to benefit from enhanced recovery pathways while mitigating their elevated risk profile. The clinical tension between HbA1c targets and patient achievability warrants pragmatic discussion with the multidisciplinary perioperative team. While guideline-recommended HbA1c targets of 8% or below are evidence-based for perioperative safety, Some patients with complex diabetes presentations, including those on insulin therapy or those with brittle glycemic control patterns, may have difficulty achieving or maintaining targets below 8% despite intensive medical management. In these patients, the absolute HbA1c value should be placed in context within the broader clinical picture. A patient with a preoperative HbA1c of 8.5%, who demonstrates consistent glucose monitoring compliance, understands sick day management principles, and has reliable access to follow-up care, may actually be at lower risk than a patient with an HbA1c of 7.8%, who demonstrates poor adherence or limited health literacy. The distinction between insulin-treated and non-insulin-treated diabetes carries important prognostic implications. Insulin-treated diabetes is associated with greater glucose variability, higher risk of both hyperglycemia and hypoglycemia during the perioperative period, increased length of stay burden with an odds ratio of 2.2, and greater diabetes-related morbidity. By contrast, non-insulin treated diabetes managed with oral agents or insulin sensitizers demonstrates significantly lower perioperative complication rates. And when glycemic control is optimized, these patients achieve outcomes equivalent to non-diabetic populations in fast-track settings. Now let's move into Module 2, which covers enhanced recovery after surgery protocols, perioperative pain management, and venous thromboembolism prophylaxis. We'll start with the contemporary standard of ERAS. Enhanced recovery after surgery protocols have become the perioperative standard of care for primary total hip arthroplasty, fundamentally changing the surgical episode from a prolonged inpatient experience to an optimized, patient-centered pathway. The ERAS Society Consensus Statement, developed through systematic review and expert panel deliberation, recommends 17 topic areas spanning the preoperative, intraoperative, and postoperative phases. Key elements include preoperative patient education and expectation setting, minimized preoperative fasting with carbohydrate loading, preference for regional anesthesia through neuraxial or peripheral nerve blocks, opioid-sparing multimodal analgesia incorporating acetaminophen, non-steroidal anti-inflammatory drugs, COX-2 inhibitors, and local anesthetic infiltration, routine tranexamic acid administration, avoidance of unnecessary surgical drains and urinary catheters, active prevention of perioperative hypothermia, and early post-operative mobilization. Preoperative carbohydrate loading represents a simple yet evidence-based intervention that reduces post-operative insulin resistance and improves perioperative outcomes. Here's how it works. Administration of a carbohydrate-rich beverage, typically 12.5% maltodextrin solution, 400 milliliters 2 hours preoperatively, maintains hepatic glycogen stores and reduces peripheral insulin resistance during the immediate postoperative period. This attenuates the catabolic surgical stress response. It's a simple intervention that reduces postoperative nausea and vomiting, improves patient satisfaction scores, and may reduce length of stay. Combined with the elimination of overnight fasting for clear liquids, allowing clear fluids up to 2 hours preoperatively and food up to 6 hours preoperatively, these adjustments represent a substantial quality of life improvement for patients undergoing planned surgery while maintaining aspiration safety. Let's turn to multimodal analgesia protocols, which integrate multiple pharmacological agents acting through distinct mechanisms to achieve opioid-sparing pain control. Acetaminophen is administered at 975 to 1,000 milligrams 3 to 4 times daily, with a maximum of 3,000 to 4,000 milligrams daily as the foundational analgesic, providing ceiling analgesia at lower doses with minimal side effects in patients without hepatic dysfunction. Non-steroidal anti-inflammatory drugs, most commonly celecoxib 200 milligrams twice daily or meloxicam 7.5 to 15 milligrams daily, selected for renal safety over non-selective NSAIDs, target inflammatory pain and reduce both opioid requirements and opioid-related adverse effects. Local anesthetic infiltration anesthesia, administered intraoperatively as a liposomal bupivacaine-based solution with a maximum of 266 milligrams combined with ketorolac, provides direct tissue anesthesia and is associated with significant reductions in postoperative opioid consumption. Tranexamic acid, administered either intravenously at 1 to 1.5 grams or topically at 1 to 3 grams, inhibits fibrinolysis and reduces postoperative bleeding without increasing thrombotic risk. When these agents are combined within a structured protocol and integrated with regional anesthesia, postoperative opioid requirements typically decrease by 40 to 50% compared to conventional opioid-centric approaches, while functional outcomes and patient satisfaction improve. Now let's dig into regional anesthesia and periarticular infiltration in greater detail, along with the aggregate evidence supporting ERAS in arthroplasty. Regional anesthesia techniques are a cornerstone of ERAS-based pain management for THA, providing superior early analgesia compared to general anesthesia alone while enabling earlier mobilization. Neuraxial anesthesia, including spinal and combined spinal epidural techniques, remains the preferred primary anesthetic for THA in most ERAS protocols. Meta-analytic evidence demonstrates reduced blood loss, lower deep vein thrombosis rates, decreased pulmonary complication risk, and shorter time to first mobilization compared to general anesthesia. Peripheral nerve blocks, specifically the fascia iliaca compartment block and the paracapsular nerve group block, known as the PEN block, provide targeted analgesia to the hip joint while preserving quadriceps motor function, a critical consideration for early postoperative mobilization. The PEN block, targeting the articular branches of the femoral, obturator, and accessory obturator nerves under ultrasound guidance, has gained increasing adoption due to its motor-sparing profile. Patients receiving PEN blocks demonstrate equivalent pain control to femoral nerve blocks, but significantly better quadriceps strength, enabling earlier and safer ambulation. Periarticular local infiltration analgesia, involving direct injection of a multimodal cocktail, typically ropivacaine or bupivacaine combined with ketorolac, epinephrine, and occasionally corticosteroid, into the hip capsule, periosteum, and surrounding soft tissues during surgery, provides 12 to 24 hours of local analgesia and reduces early postoperative opioid consumption by 30 to 40%. When combined with liposomal bupivacaine formulations, the analgesic duration extends to 48 to 72 hours, covering the critical early mobilization window. And the numbers supporting ERAS in arthroplasty are strong. Zhang and colleagues in 2024 conducted a systematic review and meta-analysis encompassing 407 studies and 76,971 patients. They found that ERAS implementation significantly shortens hospital length of stay by a weighted mean difference of negative 2.65 days, and that result was highly statistically significant with a p-value under 0.001. For those who want a refresher, the p-value tells us the probability that a result this large happened by chance alone. The smaller the number, the more confident we can be it's a real effect. ERAS also reduced transfusion rates with an odds ratio of 0.00, p less than 0.001, and lowered 30-day postoperative mortality with an odds ratio of 0.46, significant at p equals 0.01. All of this came without increasing complication rates or hospital readmissions. These findings are clinically and economically significant, as even modest reductions in length of stay translate to substantial healthcare cost savings at the institutional level. Randomized trial data back up those meta-analytic findings. Gotts and colleagues in 2024 demonstrated in a randomized clinical trial that patients managed under ERAS protocols achieved significantly better timed up and go test results and walking distances through the 6th postoperative day compared to conventional care, with no increase in pain or adverse events. ERAS-based multimodal pain nursing, as evaluated by Feng and Yu in 2026, yielded lower numerical rating scale pain scores at all postoperative time points. Reduced opioid consumption within 48 hours, 39.6 versus 52.4 morphine milligram equivalents, less than 0.001. Earlier ambulation initiation at 23.1 versus 31.2 hours. Less than 0.001, shorter hospital stay at 7.3 versus 9.0 days. Less than 0.001, and higher Harris hip scores at 1 month postoperatively. 86.8 versus 80.1, less than 0.001. The consistency of these benefits across different healthcare systems and study designs reinforces the generalizability of the ERA's approach. Now, let's cover perioperative blood management and tranexamic acid administration, which has become a standard component of ERA's protocols for THA. Tranexamic acid is supported by high quality evidence demonstrating significant reductions in perioperative blood loss and transfusion requirements without increased thromboembolic risk. Here's how it works. The antifibrinolytic mechanism involves competitive inhibition of plasminogen activation, which stabilizes fibrin clot formation at the surgical site. This is particularly effective during the hyperfibrinolytic state induced by surgical trauma and tourniquet release. Intravenous administration of 1 to 1.5 grams at induction of anesthesia with an optional repeat dose at wound closure reduces total blood loss by approximately 300 to 500 milliliters and transfusion rates by 50 to 60% across meta-analytic evidence. Topical application of 1 to 3 grams diluted in 50 to 100 milliliters of normal saline applied directly to the surgical wound before closure provides equivalent efficacy to intravenous administration for reducing drain output and visible blood loss, with the theoretical advantage of lower systemic absorption. Combined intravenous and topical administration may provide additive benefit, particularly in patients with higher baseline bleeding risk. Contraindications to tranexamic acid include active thromboembolic disease, history of seizures as tranexamic acid lowers the seizure threshold, and severe renal impairment with creatinine clearance less than 30 milliliters per minute, though dose reduction to 50% is appropriate for moderate renal impairment rather than complete avoidance. The cost-effectiveness picture is favorable. At approximately $5 to $15 per dose, prevention of even a single allogeneic blood transfusion, costing $200 to $1,200 per unit, including testing, processing, and administration, represents a substantial economic benefit on top of the clinical advantage of avoiding transfusion-related complications, including febrile reactions, volume overload, and immunomodulation. Let's now turn to venous thromboembolism prophylaxis, focusing on risk-stratified approaches. Pharmacological venous thromboembolism prophylaxis is mandatory after total hip arthroplasty, but the optimal agent should be selected based on individual patient risk stratification. The field has evolved significantly with the availability of direct oral anticoagulants. Young and colleagues in 2025, in a thorough network meta-analysis, demonstrated that factor XA inhibitors, specifically rivaroxaban and apixaban, significantly reduce postoperative VTE compared with low molecular weight heparin, with an odds ratio of 0.55, confidence interval 0.42E compared 0.5 without increasing the risk of major bleeding. That favorable efficacy to safety ratio has positioned direct oral anticoagulants as preferred first-line agents for most THA patients. Risk stratification is essential for selecting the appropriate prophylactic agent. Manser and colleagues in 2025 recommend low-dose aspirin at 81 milligrams twice daily for low-risk elective THA patients, specifically those without prior VTE history, active malignancy, known thrombophilia, or significant obesity, while reserving anticoagulant therapy for patients with elevated risk profiles. This stratified approach acknowledges that aspirin provides adequate prophylaxis for a substantial proportion of elective THA recipients, while avoiding the bleeding risks and monitoring requirements associated with anticoagulant therapy. Duration of prophylaxis is another critical decision point. Extended duration prophylaxis of 28 to 35 days versus short duration prophylaxis of 10 to 14 days produces substantially different safety and efficacy profiles. Extended prophylaxis reduces symptomatic deep vein thrombosis and pulmonary embolism incidence, whereas short-duration prophylaxis results in higher DVT rates, odds ratio 1.87, confidence interval 1.55 to 2.26, and higher PE rates, odds ratio 1.80, confidence interval 1.23 to 2.62. For elective THA patients, extended duration anticoagulant prophylaxis of typically 28 to 35 days is recommended, while aspirin prophylaxis for low-risk patients may be limited to 10 to 14 days. You'll want to counsel patients regarding the importance of medication adherence and provide clear instructions about the prophylaxis timeline, as premature discontinuation is a common cause of late thromboembolism. Here's a finding worth paying close attention to. For patients discharged to inpatient rehabilitation or skilled nursing facilities, Ho and colleagues in 2025 demonstrated that in this higher risk population, anticoagulants yielded nearly half the VTE risk compared to aspirin alone, 2.3% versus 4.4%, odds ratio 0.52, confidence interval 0.37 to 0.72. This has direct implications for discharge planning. Patients whose rehabilitation needs require institutional care should receive anticoagulant prophylaxis regardless of their baseline risk profile, as the institutional setting itself confers additional thrombotic risk through reduced mobility and prolonged recumbency. Intermittent pneumatic compression devices represent an adjunctive mechanical strategy for VTE prevention, particularly for patients with contraindications to pharmacological prophylaxis or for those requiring additional risk mitigation. These devices promote venous return through cyclical leg compression, reducing stasis within the deep venous system. Meta-analytic evidence demonstrates that sequential pneumatic compression reduces symptomatic VTE risk by approximately 60%, odds ratio 0.40, compared to no mechanical prophylaxis. While pneumatic compression is less effective than pharmacological prophylaxis alone, when combined with pharmacological agents, it provides additive benefit in very high-risk patients. Contraindications include acute cellulitis, severe peripheral arterial disease, and acute compartment syndrome. For postoperative THA patients, pneumatic compression can be initiated in the recovery room and continued during early hospitalization, particularly for those with extended length of stay or institutional discharge, typically for the duration of hospitalization or until the patient achieves independent mobilization. Now, let's cover wound closure and incision management, which rounds out Module 2. Contemporary wound management after THA has been informed by a rigorous international Delphi consensus process. Ainsley Garcia and colleagues in 2024 synthesized expert opinion from arthroplasty surgeons worldwide, generating recommendations specific to total hip arthroplasty incision management. The consensus favors barbed sutures over non-barbed sutures for deep closure, subcuticular sutures over skin staples for superficial closure, mesh adhesive dressings over impregnated dressings for routine wound coverage, application of negative pressure wound therapy for patients at elevated risk for wound complications, including those with obesity, diabetes, or immunosuppression, and use of triclosan-coated sutures to reduce surgical site infection rates. These evidence-informed recommendations provide a standardized framework for wound management that all members of the interdisciplinary team should understand, as wound assessment and dressing management frequently fall within the scope of nursing and rehabilitation professionals. Advanced wound dressing technology has substantially improved postoperative wound management and complication prevention. Mesh adhesive dressings, which combine absorbent mesh layers with dermatological adhesive, provide superior moisture management compared to traditional gauze while allowing greater patient mobility and reduced adhesion-related skin trauma during dressing changes. Silver-impregnated dressings, while effective against gram-negative organisms, offer no advantage over standard dressings in non-infected wounds and may actually delay wound epithelialization. Newer options, including moisture-retentive hydrogel dressings and foam dressings, maintain an optimal moist wound environment that promotes epithelial migration and reduces pain during dressing changes. For high-risk patients, specifically those with obesity defined as a BMI greater than 30, uncontrolled diabetes with HbA1c greater than 8%, immunosuppression or revision surgery, negative pressure wound therapy, or NPWT, applied for 24 to 48 hours intraoperatively and continued postoperatively until suture removal provides superior outcomes. Meta-analytic evidence demonstrates that NPWT reduces surgical site infections by approximately 35%, odds ratio 0.65, and seroma formation by approximately 40% compared to standard dressings in high-risk populations. Implementation requires appropriate negative pressure settings, typically 75 to 125 millimeters of mercury continuous or intermittent foam or gauze interface selection based on wound characteristics and scheduled system monitoring and changes. The economic case is compelling. While NPWT systems cost $400 to $600 per application, prevention of a single surgical site infection, with associated costs exceeding $15,000 to $20,000, justifies this intervention in identified high-risk populations. Let's move into Module 3, which covers early mobilization, weight-bearing, and evolving hip precautions. We'll start with same-day and next-day mobilization protocols. The shift toward early postoperative mobilization represents one of the most impactful changes in contemporary THA care. Systematic review evidence demonstrates that mobilization within 24 hours of surgery reduces hospital length of stay by approximately 1.8 days, confidence interval 1.1 to 2.6, without increasing adverse events. That establishes early mobilization as both safe and effective across diverse patient populations. The clinical benefits extend to same-day mobilization. Oberfeld and colleagues in 2021 demonstrated that initiating mobilization on the day of surgery, approximately 4 hours postoperatively, reduces time to readiness for discharge compared to next-day mobilization, 3.25 versus 3.99 days, less than 0.01. And this benefit was observed even in patients traditionally considered higher risk, including those aged 75 years and older, those with body mass index of 30 or greater, and those classified as ASA 3 or higher. These findings have been incorporated into contemporary ERAS pathways, where same-day mobilization is now the expected standard rather than the exception. Implementing same-day mobilization requires institutional coordination, particularly around operating room scheduling and nursing staffing. The optimal approach involves operating room start times in the morning, preferably before 10 a.m., which allows 4 to 6 hours of recovery before the mobilization attempt. Physical therapy should assess the patient approximately 2 to 4 hours post-operatively when initial anesthesia and pain medication effects are waning, but the patient remains hospitalized under close monitoring. The initial mobilization session typically includes bed mobility training, transfer training, particularly sit-to-stand from a bed or chair, and standing with bilateral crutches or a walker for 1 to 5 minutes, depending on pain, vital sign stability, and patient confidence. Pain management is critical during this window. Peak opioid dosing, often given before or immediately after the mobilization attempt, enables participation while reducing the risk of opioid-induced sedation. Nursing monitoring during early mobilization includes continuous pulse oximetry, blood pressure monitoring, and assessment of orthostatic vital signs. With mobilization discontinued if systolic blood pressure drops more than 30 millimeters of mercury, or diastolic pressure drops more than 15 millimeters of mercury from baseline, if oxygen saturation falls below 88%, or if the patient reports concerning symptoms. Activity tracking data provide objective insight into the recovery trajectory following early mobilization protocols. Goeb and colleagues in 2021 reported that average daily step counts increased progressively from 1,098 at postoperative week 1 to 6,069 at week 6, with a strong inverse correlation between increasing step counts and improving hip disability and osteoarthritis outcome score joint replacement scores, R equals negative 0.981 to less than 0.001. That validates daily step count as a meaningful objective marker of functional recovery and supports its use in monitoring rehabilitation progress, whether through consumer-grade wearable devices or formal activity monitoring systems. For rehabilitation professionals, these benchmarks provide concrete targets for patient education and goal setting during the early recovery period. Despite the strong evidence supporting early mobilization, implementation barriers persist in many institutional settings. Common barriers include operating room scheduling, that places THA cases in afternoon slots, leaving inadequate recovery time for same-day mobilization, insufficient physical therapy staffing for weekend and evening coverage, nursing concerns about patient safety during early ambulation, particularly with concurrent anticoagulation and residual anesthetic effects, and patient anxiety about postoperative pain during movement. Successful early mobilization programs address these barriers through systematic institutional protocols, morning first scheduling for THA cases, dedicated physical therapy staffing models that include weekend coverage, standardized nursing mobilization protocols with clear safety criteria including systolic blood pressure above 90 millimeters of mercury, heart rate below 120 beats per minute, oxygen saturation above 92%, pain less than 7 out of 10, and absence of significant orthostatic symptoms, and preoperative patient education that establishes clear expectations for same-day or next-day mobilization. Here's what the quality improvement data show. Institutions implementing these programs see same-day mobilization compliance rates increase from 35 to 45% at baseline to 85 to 95% within 6 months of protocol implementation, with concurrent reductions in length of stay averaging 0.8 to 1.2 days without increases in falls, readmissions, or complications. The financial impact is substantial. Each day of reduced length of stay saves approximately $2,000 to $3,500 per patient in direct hospital costs. For a 200-case annual THA program, a one-day average length of stay reduction generates $400,000 to $700,000 in annual cost savings. Let's turn now to weight-bearing protocols after uncemented total hip arthroplasty. The weight-bearing protocol after THA has evolved considerably. Systematic review evidence demonstrates moderate to strong support for immediate unrestricted weight-bearing after uncemented THA with no adverse effects on femoral stem subsidence or osseous integration. The recommended gait progression includes initiating a reciprocal gait pattern with bilateral crutches, transitioning to a single cane when the patient can ambulate without a limp, and discontinuing assistive devices when gait is normalized. Protected weight bearing should be considered specifically for stair climbing during the first postoperative weeks due to the high torsion loads generated during this activity. This progressive approach maximizes early functional independence while respecting the biomechanical demands of specific activities. While unrestricted weight-bearing is well supported for uncemented press-fit femoral stems, the fixation method does influence early weight-bearing decisions in specific populations. Cemented femoral components, which achieve immediate mechanical fixation through polymethyl methacrylate interdigitation with cancellous bone, allow full unrestricted weight-bearing from the first postoperative day regardless of patient characteristics. Uncemented stems, by contrast, rely on biological fixation through osseointegration, a process requiring 4 to 12 weeks for initial bone on-growth, during which micromotion at the bone implant interface must be minimized to prevent fibrous encapsulation rather than bony fixation. Despite this theoretical concern, clinical evidence demonstrates that immediate full weight bearing after uncemented THA doesn't increase stem subsidence beyond acceptable thresholds of less than 2 millimeters at 2 years, or compromise long-term fixation in the vast majority of patients. The exception is patients with compromised bone quality, specifically those with severe osteoporosis with T-score less than -3.0, periprosthetic fracture repair, or revision stems with extended proximal porous coating, for whom protected weight bearing at toe touch to partial weight bearing at 25 to 50% body weight for 4 to 6 weeks is typically recommended. Rehabilitation professionals should verify the fixation method and surgeon-specific weight-bearing order for each patient as institutional variation persists despite the evidence favoring early unrestricted protocols. Now, let's examine the shift away from routine hip precautions. This is arguably the most significant change in contemporary THA rehabilitation. Traditional precaution protocols, restricting hip flexion beyond 90 degrees, adduction past midline, and internal rotation were originally implemented to prevent prosthetic dislocation but have been increasingly questioned as implant design, surgical technique, and soft tissue repair have improved. The surgical approach fundamentally influences precaution necessity and design. Anterior and anterolateral approaches, which spare or repair the hip abductor musculature, inherently stabilize the hip prosthesis against posterior dislocation and allow unrestricted protocols in most cases. Posterior approach THA, while accessing the hip through a natural internervous plane, requires repair of the external rotators and posterior capsule, structures critical for preventing posterior dislocation. For posterior approach patients, three precaution strategies exist with different evidence profiles. Strict traditional precautions with no hip flexion beyond 90 degrees, no adduction, and no internal rotation. Modified precautions restricting only the combined position of flexion, adduction, and internal rotation simultaneously, the so-called leg shaving position, and no precautions at all. The modified precaution approach represents a pragmatic middle ground that eliminates most functional restrictions, allowing patients to independently don socks, tie shoes, and navigate stairs, while still avoiding the single position most biomechanically associated with posterior dislocation. Surgeon preference, patient reliability, and institutional protocols guide precaution selection. Clinicians should understand that unrestricted protocols carry an increased but still low absolute dislocation risk, typically less than 2% at 1 year, whereas modified precautions reduce dislocation risk further while preserving functional independence. Lightfoot and colleagues in 2021, in a before and after study of 237 patients, found that those managed without any postoperative hip precautions achieved significantly equivalent Oxford hip scores at 3 months. Mean difference equals negative 0.82, confidence interval negative 2.64 to 1.00, compared to those receiving traditional strict precautions, with no increase in dislocation or other complications. The no precautions group reported significantly less pain and greater functional ability during the first postoperative week, a finding attributable to the psychological and functional freedom of moving without arbitrary restrictions. Guo and colleagues in 2024 provided meta-analytic confirmation through a systematic review of randomized controlled trials, finding no statistically significant difference in hip dislocation rates with or without hip precautions after THA performed via the posterior approach. The group managed without precautions also demonstrated better Hus-Josh-JR scores and earlier discontinuation of mobility aids. A grade at allotment guideline panel convened by Rusby and colleagues in 2025 synthesized the available evidence and issued conditional recommendations in favor of unrestricted postoperative protocols, finding no significant difference in early dislocation rates when movement restrictions were eliminated, risk ratio 0.44, confidence interval 0.16 to 1.20, or when assistive devices weren't mandated, risk ratio 0.75, confidence interval 0.52. The panel acknowledged that while the point estimates favored unrestricted protocols, the confidence intervals crossed unity, warranting the conditional rather than strong recommendation. For patients undergoing posterior approach THA, modified precautions that restrict only the combined position of flexion, adduction, and internal rotation offer a pragmatic compromise. Under this modified protocol, 74% of patients return to work by postoperative week 4. Patients undergoing anterior approach THA generally have even fewer restrictions due to the inherently more stable anterior capsular approach. The collective evidence supports a shift from prescriptive universal precautions to individualized protocols based on surgical approach, implant stability, patient-specific risk factors, and surgeon preference. Communicating this evolution away from routine hip precautions requires careful patient education. Many THA patients arrive with expectations set by well-meaning family members or outdated internet sources describing strict precaution protocols. Effective education should acknowledge the historical rationale for precautions, explain why contemporary evidence supports modification or elimination for most patients, and clarify the specific protocol the patient's surgeon recommends. For patients undergoing posterior approach THA without precautions, reassurance regarding the low dislocation risk of less than 2%, an explanation that current implants and surgical techniques are substantially more reliable than those of prior decades helps set realistic expectations. Visual demonstrations of safe movement patterns showing that normal stairs, sitting in cars, and bending to pick up objects are permissible tangibly communicate functional freedom. For patients requiring modified precautions, specific instruction regarding the avoided position, combining hip flexion past 90 degrees, adduction past midline, and internal rotation simultaneously provides clear guidance without the psychological burden of multiple vague restrictions. reinforcing that precautions exist to optimize already excellent outcomes rather than preventing catastrophic complications, helps patients understand the proportionate nature of the recommendations. Written materials, including diagrams and home exercise sheets, should align with the surgeon's specific precaution protocol, as inconsistent messaging between providers, whether surgeon, therapist, or nurse, creates confusion and undermines patient confidence and adherence. We're now moving into Module 4, which addresses rehabilitation pathways, risk stratification, setting selection, and discharge planning. Let's start with the evidence on formal physical therapy versus self-directed rehabilitation. One of the most consequential evidence-based findings in THA rehabilitation is that formal physical therapy isn't universally required for favorable outcomes. The AAOS 2024 Clinical Practice Guideline states that high-quality evidence supports either formal physical therapy or unsupervised home exercise after THA for symptomatic osteoarthritis, issuing a moderate strength recommendation that formal PT isn't mandated for all patients. This guideline level recommendation is grounded in a substantial body of evidence. Most notably, the landmark randomized controlled trial by Austin and colleagues in 2017, which randomized 120 THA patients to either self-directed home exercise or formal outpatient physical therapy. They found no significant difference in any functional outcome at any time point. Harris Hip Score at p equals 0.82. WOMAC at p equals 0.80, and SF36 physical health at p equals 0.90. A thorough meta-analysis by Hansen and colleagues in 2019 pooled 7 randomized controlled trials comparing supervised exercise therapy to unsupervised or home-based exercise, finding no significant differences in short-term or long-term functional outcomes, pain scores, or range of motion in THA patients. The pooled effect size for Harris Hip Score comparison was 0.42, confidence interval -20.27 to 21.10, p equals 0.232. No clinically meaningful difference between supervision strategies. This finding persisted across subgroup analyses stratified by patient age, operative approach, and outcome measurement timing, showing remarkable consistency. The takeaway here is that the content and consistency of exercise, rather than the supervision context, is the primary determinant of outcome. This identifies an opportunity to allocate resources toward ensuring all THA patients receive evidence-based exercise education and a clear home program, rather than mandating facility-based supervision. Despite those findings, it would be clinically inappropriate to conclude that no patient benefits from formal rehabilitation. Approximately 1/3 of THA patients may still need supervised physical therapy. In a retrospective study of 941 consecutive THA patients enrolled in a web-based, self-directed program, 31.3% were subsequently prescribed outpatient physical therapy, with 88.2% based on perceived clinical need and 10.8% at the patient's own request. Predictors of requiring formal PT included female sex and lower preoperative SF12 physical component scores, suggesting that patients with greater baseline functional impairment are more likely to benefit from supervised intervention. So the clinical challenge isn't whether to offer rehabilitation, but rather how to accurately identify which patients require formal supervision and which can safely recover with self-directed programs. Let's now examine the risk stratification tools that help guide rehabilitation pathway selection, specifically the Risk Assessment and Prediction Tool, known as the RAPT, and the Preoperative Timed Up and Go test. The RAPT is the most widely validated preoperative screening instrument for predicting rehabilitation needs and discharge destination after THA. It's a 6-item questionnaire generating a score from 1 to 12 based on patient age, sex, walking distance, gait aid use, community support, and anticipated caregiver availability. In a validation study of nearly 18,000 patients, LeBrun and colleagues in 2023 demonstrated that every 1-point increase in RAP score was associated with 1.82-fold increased odds of home discharge, p less than 0.01, zero point 0.2 days shorter hospital length of stay, p less than 0.001, and 1.13-fold increased odds of ambulating on postoperative day 0, p less than 0.001. Scores of 10 or above predict home discharge with greater than 90% accuracy and identify patients suitable for self-directed rehabilitation. Scores of 8 to 9 indicate intermediate risk appropriate for telerehabilitation or limited formal physical therapy. Scores below 7 indicate high risk requiring formal supervised rehabilitation. Bloom and colleagues in 2024 enhanced the predictive accuracy of the RAPT by incorporating additional variables including non-married status, ASA classification 3 or 4, low serum albumin, Charlson Comorbidity Index, and depression, improving predictive accuracy to 90.1%. The preoperative timed up and go test serves as the single most predictive performance-based measure. A tug time of less than 10 seconds indicates 76.7% sensitivity and 93.2% specificity for independent ambulation at 6 months, while a tug time exceeding 10.5 seconds predicts delayed recovery requiring formal physical therapy. When the RAPT and TUG are used together, clinicians have a dual assessment framework combining patient-reported and performance-based data to guide rehabilitation pathway selection. Let's turn to discharge disposition trends, fast-track pathways, and setting selection. National data reveal a dramatic shift in discharge patterns following THA. Home discharge rates have risen from approximately 70% in 2011 to over 92% by 2021 in the United States, with concurrent decreases in length of stay, readmission rates, and complications. In contemporary fast-track programs, home discharge approaches 99%, with only approximately 1% of patients requiring transfer to a rehabilitation facility. This reflects the cumulative impact of ERAS protocols, refined anesthetic and pain management strategies, and the evidence-based shift away from precautions and prolonged immobilization. Fast-track programs reduce hospital length of stay to 1 to 3 days compared to traditional pathways averaging 5 to 7 days, without increasing complication rates or readmissions. The distinction between elective THA discharge patterns and trauma hip fracture discharge patterns remains substantial. While elective patients now routinely discharge home on postoperative day 1 or 2, trauma patients continue to demonstrate home discharge rates of only 35 to 50%, reflecting both medical complexity and premorbid functional status differences. The economic case for home-based rehabilitation is compelling. A Canadian analysis by Mahomed and colleagues directly compared costs, demonstrating that home-based rehabilitation cost 11,082 Canadian dollars per patient compared to 14,532 dollars for facility-based care, representing a 24% cost reduction while achieving equivalent or superior functional outcomes. For a 200-case annual THA program, exclusive use of home-based pathways would generate nearly $700,000 in direct cost savings. Home-based rehabilitation achieves these cost reductions while actually improving patient satisfaction due to shorter commute times, greater schedule flexibility, and the psychological benefit of recovering in familiar environments. For discharge prediction, the predicting location after arthroplasty nomogram or plan achieves a concordance index of 0.723 for THA, while the AMPAC 6-clicks basic mobility score achieves 0.813. When used together, concordance reaches 0.836. When both tools agree on home discharge, the actual home discharge rate is 98.0% with lower readmission rates, providing high confidence for discharge planning decisions. And here's a finding that drives the point home. Patients discharged to skilled nursing facilities have higher readmission rates even after adjusting for functional status. Adjusted relative risk 1.57, confidence interval 1.23 to 2.01 at 90 days. That reinforces the preference for home discharge when feasible. Home-based rehabilitation achieves outcomes comparable to facility-based care. The landmark PEAK trial by Nelson and colleagues in 2020 demonstrated non-inferiority of telerehabilitation to in-person physiotherapy on the HUS quality of life subscale at 6 weeks, P equals 0.970, with higher patient satisfaction for ease of attending appointments and greater home exercise compliance at 86% versus 74%, P equals 0.048. The transition from hospital to home represents a vulnerable period with elevated risk for adverse events, particularly falls, medication errors, and wound complications. Structured transitional care interventions, including pre-discharge home safety assessment by occupational therapy, medication reconciliation by pharmacy, written discharge instructions with teach-back verification, and scheduled follow-up contact within 48 to 72 hours of discharge, reduce 30-day readmission rates by 15 to 25% compared to standard discharge processes. Home health nursing visits during the first postoperative week provide wound assessment, vital sign monitoring, medication management support, and early identification of complications including infection, DVT, and prosthetic instability. Let's now discuss telerehabilitation candidacy screening and same-day discharge criteria, which round out Module 4. Patients classified as intermediate risk on the RAPT with scores 7 to 9 represent the optimal telerehabilitation population, but additional screening is required to ensure readiness and safety. Digital health literacy assessment using validated instruments, such as the Digital Health Literacy Questionnaire, should be completed preoperatively to identify patients requiring technology support or in-person alternatives. Practical readiness criteria include reliable broadband internet access with minimum 5 megabits per second upload and download speed for real-time video, a smartphone or tablet with front-facing camera capability, adequate home space for exercise performance visible on camera, and cognitive capacity to follow remote exercise instruction independently or with caregiver assistance. Patients who meet functional criteria for telerehabilitation but fail digital literacy screening should be offered hybrid models combining limited in-person visits, typically 2 to 4 sessions during the first 6 weeks, with simplified asynchronous telerehabilitation using recorded exercise videos and telephone check-ins. For patients in rural or underserved areas where in-person physical therapy access is limited, device loaner programs and pre-surgery technology orientation sessions can substantially improve telerehabilitation feasibility and adherence. Same-day discharge THA is safe and feasible even for patients with elevated comorbidity profiles when implemented within structured institutional protocols. The Outpatient Arthroplasty Risk Assessment Score, known as the AURA, evaluates 52 medical comorbidities and achieves a positive predictive value of 81.6% for same-day or next-day discharge, significantly superior to the ASA physical status classification at 56.4%, less than 0.001, and the Charlson Comorbidity Index at 70.3%, p equals 0.002. When the ORA score is combined with deliberate patient education establishing expectations for outpatient discharge, the odds of early discharge increase to 2.7, confidence interval 1.7 to 4.2. Successful same-day discharge programs emphasize earlier operating room start times, with an odds ratio of 11.56 for same-day discharge with start times before 9 a.m. versus after 12 p.m., ERAS-based multimodal analgesia, early mobilization with physical therapy assessment 2 to 4 hours postoperatively, thorough patient education, reliable social support for the first 24 to 48 hours, and institutional backup capacity for overnight observation. Specific comorbidities warrant particular attention in same-day discharge planning. Patients with well-controlled diabetes with HbA1c less than 8% can safely participate in same-day discharge pathways when perioperative glucose monitoring protocols are in place. Conversely, recent myocardial infarction within 6 months, uncontrolled cardiac arrhythmias, or severe symptomatic heart failure typically necessitate overnight observation. Operating room start time has surprising prognostic significance. Procedures beginning before 9 a.m. achieve same-day discharge in 78 to 82% of cases, whereas those starting between 11 a.m. and 1 p.m. achieve only 45 to 52%, and those after 2 p.m. achieve fewer than 30% same-day discharge. That reflects the inadequate recovery window for proper pain control assessment and mobility demonstration before late afternoon discharge. We're now starting Module 5, which details phase-specific exercise programming, balance, and proprioception training. Let's begin with the immediate post-operative phase covering days 0 through 5. The cornerstone of rehabilitation after primary THA is early mobilization, typically initiated on the day of surgery or postoperative day 1, as we discussed in Module 3. During the immediate postoperative phase, the primary goals are prevention of complications including deep vein thrombosis and pneumonia, restoration of basic functional independence for discharge, and initiation of neuromuscular activation. The exercise protocol during this phase includes bed mobility and transfer training 2 to 3 times daily. Ankle pumps performed 10 to 15 repetitions every hour while awake to promote venous return, quadriceps and gluteal isometric sets with a 5-second hold for 10 to 15 repetitions across 3 sets, performed 2 to 3 times daily, active assisted hip and knee flexion and extension within tolerable range, hip abduction in supine or sideline positions, day training with the appropriate assistive device. Progression criteria for advancing beyond this phase include independent transferability, ambulation of 30 to 50 meters, basic activities of daily living performance, and medical stability. Now, let me walk through the detailed exercise parameters. Isometric quadriceps and gluteal sets should be performed with a 5-second maximal voluntary contraction followed by a 5-second relaxation, repeated for 10 to 15 repetitions, performed during 2 to 3 therapy sessions daily or self-directed by the patient hourly. Hip abduction in supine position is performed through a pain-free range, typically 20 to 30 degrees. One set of 10 to 15 repetitions, 2 to 3 times daily, with emphasis on isolated abductor activation rather than substitution patterns involving hip external rotation or lumbar extension. Active assisted hip flexion initially targets 60 to 70 degrees, advancing to 80 to 90 degrees by postoperative day 3 as pain and range of motion improve. Ankle pumps, performed 10 to 20 repetitions every 1 to 2 hours while awake, should involve full plantar flexion followed by dorsiflexion through the complete available range, serving dual purposes of promoting venous return and maintaining distal lower extremity motor control. Gait training progresses from bilateral crutches with partial weight bearing at 25 to 50% body weight on postoperative day 0 to 1, to full weight bearing with bilateral crutches by postoperative day 2, to single crutch or cane by postoperative day 3, with distance targets of 10 to 20 meters on postoperative day 0 to 1, 20 to 30 meters on day 2, and 30 to 50 meters by day 3 or 4. The walking pattern should approximate a symmetrical cadence and stride length, with clinicians monitoring for compensatory patterns including ipsilateral trunk lean, gluteal gait, and excessive pelvic tilt that can lead to chronic gait dysfunction if not addressed early. Moving to the early recovery phase covering weeks 1 through 6. The early recovery phase targets restoration of functional range of motion, progressive strengthening, improved gait quality, and independence in activities of daily living. Exercise prescriptions during this phase become more diverse and demanding, incorporating supine heel slides and hip abduction, prone hip extension, standing hip flexion, extension, and abduction. Straight leg raises in all 4 directions with progressive loading using 0.5 to 2 kilogram ankle weights, mini squats through 0 to 45 degrees of knee flexion, forward step-ups on a 4 to 6 inch step, bridging exercises, clamshells, and resistance band exercises. Functional training includes sit-to-stand practice from various chair heights, gait training progressing toward independence for 10 to 20 minutes 2 to 3 times daily, and stair climbing with progressive reduction of upper extremity support. 3 adjunctive interventions have convincing evidence for the early postoperative period. Treadmill training with partial body weight support, unilateral resistance training of the quadriceps on the operated side, and arm interval exercises with an arm ergometer. Pain monitoring during progressive exercise is essential for safe and effective rehabilitation. Pain during exercise should remain below 35 millimeters on a 0 to 100 millimeter visual analog scale. Mild pain at rest of 1 to 18 millimeters 5 AS is acceptable and typically decreases over time, despite continued load progression. This evidence-based pain monitoring threshold enables clinicians to progress exercise intensity confidently while maintaining patient safety and trust. Let's now discuss the late recovery phase covering weeks 6 through 12, with a focus on progressive resistance training. Progressive resistance training is the central component of the late recovery phase, with the strongest evidence for improving muscular strength, gait mechanics, and functional outcomes. Chen and colleagues in 2024 conducted a prospective randomized controlled trial demonstrating that progressive resistance training targeting hip flexion, extension, adduction, and abduction yields superior improvements when implemented both preoperatively and postoperatively compared to either timing alone. The combined pre and post group achieved significantly better Harris hip scores, gait velocity, cadence, and balance at 1, 3, and 12 months compared to groups receiving only preoperative or only postoperative progressive resistance training. That reinforces the value of prehabilitation as we discussed in Module 1 and demonstrates that the benefits of preoperative conditioning are amplified when continued into the postoperative rehabilitation period. For patients capable of higher intensity training, maximal strength training protocols at 85 to 90% of maximal capacity, typically structured as 4 sets of 5 repetitions performed 3 times weekly, produce substantially greater strength gains than conventional physiotherapy. Differences in leg press strength of 43 kilograms have been documented at 3 and 6 months, though these differences tend to disappear by 1 year as conventional rehabilitation patients gradually achieve similar strength levels over a longer time course. The clinical significance of accelerated strength recovery lies not in the endpoint but in the trajectory. Faster strength recovery enables earlier return to functional activities, work, and sport. Practical implementation of high-intensity progressive resistance training requires careful exercise selection and loading progression. Initial loads in weeks 6 through 8 should target 50 to 65% of estimated 1 repetition maximum, with loads advanced by 5 to 10% every 2 to 3 sessions as tolerance improves. By weeks 10 through 12, patients should progress to 80 to 90% 1 repetition maximum for exercises such as the leg press, split squat, and seated hip abduction, with loading guided by pain response maintaining pain below 35 out of 100 on visual analog scale during exercise and strength gains, assessed through functional testing such as sit-to-stand repetitions in 30 seconds or stand-to-walk distance. Beyond the 12-week mark, rehabilitation transitions towards sport-specific and activity-specific conditioning while maintaining foundational strength and balance work. Multi-joint resistance exercises emphasizing functional movement patterns become central. Forward lunges with contralateral reach, backward lunges, step-ups with progressive step height of 6 to 12 inches, lateral step-downs to target hip abduction and eccentric loading, and single-leg stance progressions provide progressive loading while incorporating functional motor patterns relevant to activities of daily living and recreational pursuits. Aerobic conditioning is progressively increased to the long-term target of 30 to 45 minutes of moderate intensity activity performed 3 to 5 times weekly, which meta-analytic evidence demonstrates is required for substantial long-term functional improvement and return to preoperative activity levels. Specific sport return protocols depend on the individual's goals. Patients returning to golf should incorporate rotational core work, gait training on variable terrain, and sport-specific practice. Those returning to tennis should emphasize lateral agility, cutting movements, and plyometric drills. Those pursuing swimming should emphasize lower extremity kick patterns. And those returning to running should follow a graduated running progression beginning at 4 to 5 months post-operatively, with a walk-run program alternating 30 seconds of walking and 30 seconds of jogging for 20 to 30 minutes 3 times weekly, progressing to continuous running by 6 to 9 months. Let's turn to balance and proprioception impairment after THA, a frequently underappreciated consequence of both hip osteoarthritis and subsequent arthroplasty. Balance and proprioception impairments persist up to 5 years after THA and significantly increase fall risk despite improvements compared to preoperative status. The mechanisms behind these deficits are complex. Osteoarthritis and the surgical procedure itself damage hip joint mechanoreceptors, specialized sensory organs in the joint capsule, ligaments, and muscles that signal joint position, movement velocity, and proprioceptive feedback. That impairs proprioception, which is the ability to sense joint position and movement. The surgical incision disrupts joint capsule innervation, and the altered biomechanics of the prosthetic joint, which lacks some of the responsive damping characteristics of the natural articulation, requires neural relearning. Contributing factors also include persistent hip abductor weakness affecting the gluteus medius and gluteus maximus, altered gait mechanics with compensatory movement patterns including increased trunk sway and reduced hip extension, reduced maximal isometric muscle strength, and decreased hip extension and lateral rotation moments that persist beyond 1 year postoperatively. Objective assessment reveals measurable deficits across multiple parameters. Postural control evaluated through center of pressure analysis shows that THA patients typically demonstrate increased center of pressure path length and velocity during static stance, increased by 20 to 40% compared to age-matched controls, indicating impaired postural stability. Single leg stance time on the operated limb is frequently reduced to 15 to 25 seconds compared to 45 to 60 seconds on the contralateral limb and 60 to 90 seconds in age-matched controls. Dynamic balance measured through the timed up and go test remains elevated at a mean of 12 to 14 seconds compared to normative values of 8 to 10 seconds in those aged 65 to 74 years. These persistent deficits correlate with increased fall incidence and risk of secondary fracture, which occur in 5 to 10% of THA patients during long-term follow-up. The clinical significance of balance deficits extends well beyond fall prevention. Patients with persistent balance impairment report reduced confidence in community ambulation, avoidance of outdoor activities on uneven terrain, reluctance to use public transportation, and decreased participation in social and recreational activities. Collectively, these contribute to social isolation and reduced life satisfaction despite otherwise successful arthroplasty outcomes. Fear of falling, which affects 30 to 50% of THA patients during the first postoperative year, creates a vicious cycle. Activity avoidance leads to deconditioning, which further impairs balance and increases actual fall risk. Cognitive behavioral approaches addressing fear of falling, combined with graded exposure to progressively challenging balance tasks in safe environments, effectively break this cycle. Assessment of fall-related self-efficacy using validated instruments such as the Falls Efficacy Scale International should complement objective balance testing to capture the psychological dimension of balance impairment. And the evidence for intervention is encouraging. A 2025 meta-analysis by Dominguez Navarro and colleagues found that balance-based interventions produce significant improvements in dynamic balance, with an SMD of 1.18, confidence interval 0.400 to 1.96, a large effect. Static balance improved with an SMD of 1.01, confidence interval 0.31 to 1.72, also a large effect. Global balance showed an SMD of 1.42, confidence interval 0.1 to 2.73, large again compared to controls in the immediate term, with low to moderate certainty of evidence. Adebero and colleagues in 2025 corroborated these findings in a systematic review focused specifically on exercise interventions for postural stability after THA. Aquatic therapy represents a valuable adjunctive modality during the late recovery phase, particularly for patients with obesity, bilateral joint disease, or exercise intolerance limiting land-based progressive resistance training. Water immersion at chest depth reduces apparent body weight by approximately 60 to 70% through buoyancy, enabling higher intensity exercise with reduced joint loading. Water temperature of 33 to 35 degrees Celsius provides additional therapeutic benefit through reduced muscle spasm, improved tissue extensibility, and enhanced relaxation. Systematic review evidence demonstrates that aquatic therapy produces equivalent improvements in pain, function, and quality of life compared to land-based therapy following THA. Contraindications include open wounds, uncontrolled urinary incontinence, active skin infections, severe cardiac instability, and fear of water. Let's wrap up Module 5 with phase-specific balance training protocols and the minimum effective dose for fall prevention. Balance training should be incorporated into rehabilitation from the early postoperative period and progress systematically. During weeks 1 through 6, static balance exercises include double leg stance, tandem stance, weight shifts in all directions, and single leg stance with upper extremity support, while dynamic balance exercises include marching in place, heel to toe walking, sidestepping, and backward walking. Beyond 12 weeks, training progresses to advanced single leg activities on unstable surfaces such as foam pads and balance boards, perturbation training with external challenges, and sport specific balance work for patients pursuing return to athletic activities. Neuromuscular re education programs targeting hip proprioception and motor control form the physiological foundation of balance training. These programs emphasize conscious attention to weight distribution during stance, coordinated hip and ankle strategies for postural adjustment, and reactive stabilization of the hip abductors during perturbations. Proprioceptive exercises include weight shifting on firm ground progressing to compliant surfaces, single leg stance with progressive surface instability, and closed eyes balance training, which removes visual compensation, forcing reliance on proprioceptive feedback. Progressive proprioceptive training should advance from firm floors to balance pads such as foam or proprioceptive discs, to foam rollers, to balance boards, with each surface reducing tactile and proprioceptive input and increasing demand on hip and ankle motor control. Perturbation training, beginning around 8 to 12 weeks postoperatively, involves external challenges to balance such as arm reaches, requiring weight shift, tandem walking with head turns, and stepping over obstacles at varying speeds, all designed to provoke and train reactive stabilization strategies. Here's the benchmark to keep in mind. The minimum effective dose for fall prevention in community-dwelling older adults requires 50 hours of exercise focusing on functional movements, leg strength, and balance, yielding a risk ratio of 0.77, confidence interval 0.71 to 0.83 for fall reduction. For THA patients, translating this 50-hour target into practical clinical recommendations suggests approximately 50 to 100 minutes of balance training per week distributed across 2 to 3 therapy or exercise sessions, or approximately 1 to 2 hours monthly across a 12-month rehabilitation trajectory. Progression criteria for balance training include ability to perform single leg stance for greater than 30 seconds with eyes open, greater than 15 seconds with eyes closed, tandem stance for greater than 30 seconds with eyes open, and a tug time of less than 10 seconds, with achievement of these milestones typically occurring between 4 and 6 months postoperatively in uncomplicated cases. We're now in Module 6, which covers interdisciplinary care, telerehabilitation, and emerging technologies. Let's start with evolving roles in interdisciplinary THA care, beginning with nursing interventions and doctor-nurse integrated care models. Nursing contributions to THA outcomes extend far beyond traditional perioperative monitoring. A systematic review and meta-analysis by Shi and colleagues in 2025 demonstrated that pain relief nursing interventions encompassing individualized patient education, multimodal analgesia coordination, and guided early ambulation protocols significantly improve activities of daily living outcomes compared to standard nursing care. Guo and Zhang in 2025 further showed that predictive nursing guided by thorough risk assessment significantly reduces deep vein thrombosis incidence, shortens hospital stays, enhances hip function as measured by the Harris Hip Score, improves ADL scores, and reduces anxiety in elderly THA patients. Integrated doctor-nurse care models, where nurses and surgeons conduct joint rounds with shared decision-making regarding pain management escalation, discharge readiness, and rehabilitation intensity, produced improved outcomes compared to sequential physician-nurse care models where recommendations are communicated rather than developed collaboratively. Winberg and colleagues in 2025 identified contextual factors affecting evidence-based nursing practice in joint arthroplasty settings, including local opinion leaders and champions, institutional culture supporting evidence adoption, team communication patterns, and nurse autonomy in care decision-making. These factors explained variance in evidence implementation beyond knowledge alone. The evolution away from routine hip precautions has fundamentally reshaped the occupational therapy role in THA rehabilitation. Traditional OT practice, centered on hip precaution education and provision of adaptive equipment, including raised toilet seats, long handled reachers, and sock aids, is increasingly unnecessary for the majority of THA patients managed under unrestricted protocols. Contemporary OT practice after THA should be individualized, focusing on activities of daily living retraining for patients with documented functional deficits, environmental adaptation for patients returning to challenging home environments, functional cognitive integration for patients with comorbid cognitive impairment, upper extremity strengthening for patients who will depend on assistive devices for ambulation, and psychosocial support for patients experiencing adjustment difficulties. The NICE guidelines specifically recommend supervised rehabilitation for patients with difficulty managing ADLs, cognitive impairments, specific rehabilitative needs, or those for whom self-directed rehabilitation doesn't meet their goals. Let's turn to preoperative patient education and digital engagement strategies. Preoperative education is a critical interdisciplinary intervention that spans professional boundaries. Baxter and colleagues in 2023 demonstrated that telemedicine-based preoperative education achieves equivalent outcomes to in-person education even for high-risk patients undergoing primary total joint arthroplasty. That's particularly significant for health systems seeking to extend preoperative optimization to geographically dispersed populations without the logistical burden of in-person visits. Enhanced preoperative education pathways have also been shown to reduce disparities in TJA outcomes, suggesting that standardized, accessible education programs may serve as an equity intervention by ensuring all patients receive consistent, high-quality preparation regardless of socioeconomic status or geographic location. Digital engagement metrics reveal important insights regarding education delivery. Knapp and colleagues in 2021 analyzed online preoperative education modules for orthopedic patients and found that video-based content achieved 87% completion rates compared to 52% for text-based modules, that mobile-compatible content achieved 73% completion compared to 48% for non-optimized formats, and that interactive elements including quizzes and calculators increased engagement time by 40% and retention by 32%. Soders and colleagues in 2018 demonstrated that patients receiving structured preoperative physical therapy education sessions achieved faster return to functional milestones, with time to ambulation without assistive device reduced by 5.3 days, confidence interval 1.2 to 9.4, and time to independent stair climbing reduced by 7.1 days, confidence interval 2.8 to 11.4, compared to those receiving standard written education alone. Let's now look at the full evidence base for telerehabilitation following THA, including patient selection and health equity considerations. Telerehabilitation has emerged as a strong evidence-based alternative to in-person physical therapy for THA patients. Wang and colleagues in 2023, in a systematic review of 11 randomized controlled trials with 1,020 participants, found no significant differences between internet-based telerehabilitation and face-to-face rehabilitation for pain. SMD, negative 0.11. Range of motion inflection. Mean difference, 0.65 degrees. Patient-reported physical function. SMD, 0.01, or patient satisfaction. SMD, negative 0.04. And here's what stands out. Telerehabilitation actually demonstrated superior outcomes in physical functional tests. SMD negative 0.54, suggesting that the structured accountability of remote monitoring may promote more consistent exercise adherence. Real-time video telerehabilitation shows attendance 8% higher and adherence 9% higher compared to in-person physiotherapy. Smartphone-based care platforms for THA rehabilitation deliver exercises through mobile applications that guide patients through prescribed movements with video demonstration, progress tracking, and synchronous or asynchronous feedback. Meta-analytic evidence indicates that asynchronous telerehabilitation, where patients perform exercises independently with recorded feedback provided afterward, achieves comparable outcomes to synchronous video sessions. Patient satisfaction for asynchronous delivery actually exceeds synchronous delivery in some studies, likely due to greater scheduling flexibility. Telerehabilitation is cost-neutral to slightly cost-saving, with studies demonstrating a mean cost difference of negative $28.90, favoring telerehabilitation, and patient time savings of 4.21 hours per episode of care reflecting eliminated travel and wait time. Smartphone-based care platforms have demonstrated reduced physical therapy utilization at 34% versus 55.4%, without differences in complications, readmissions, or functional outcomes at 90 days. But there are significant disparities in telerehabilitation readiness that demand our attention. Falvey and colleagues in 2024 reported that approximately 2 in 3 older rehabilitation users aged 70 and above were ready for video-based telerehabilitation. But readiness was significantly lower among rural-dwelling older adults. Odds ratio 0.75. Financially strained individuals. Odds ratio 0.37. Non-Hispanic Black older adults. Odds ratio 0.23. And Hispanic older adults. Odds ratio 0.17. These disparities mean that telerehabilitation, while an effective and efficient delivery model, risks widening existing healthcare inequities if implemented without deliberate attention to digital inclusion strategies. Rehabilitation programs should assess digital health literacy using validated instruments, provide technology training and equipment when needed, and maintain in-person alternatives for patients who can't access or benefit from remote care. Validated instruments for digital health literacy assessment include the Digital Health Literacy Questionnaire, or DHRQ, comprising 15 items across 5 domains with Cronbach alpha scores exceeding 0.70, and the Digital Health Literacy Tool for Arthritis Questionnaire, or DHTL-AQ, containing 34 items across 3 domains with Cronbach alpha of 0.95. Both instruments take 5 to 10 minutes to administer and identify specific competency gaps such as password management, source evaluation, and information search skills, allowing targeted training. Patients scoring in the lowest tertile require enhanced support, including device provisioning, basic technology training, simplified interfaces with large fonts, and phone-based support hotlines. Let's close out Module 6 with emerging technologies, including AI-assisted wound assessment, wearable monitoring, and robotic-assisted THA. Artificial intelligence applications for surgical site infection detection represent an emerging frontier in postoperative THA monitoring. A vision transformer model developed at the Mayo Clinic, trained on data from 6,060 patients, achieved incision detection accuracy of 0.94 with an area under the curve, or AUC, of 0.98. The AUC is essentially a prediction accuracy score that runs from 0.5, which is no better than a coin flip, up to 1.0, which would be a perfect prediction. So 0.98 is excellent. Surgical site infection detection accuracy was 0.73, AUC 0.81. While these performance metrics are promising, the technology remains in early validation stages. A systematic review of 24 studies encompassing 85 machine learning models found that 81% were only internally validated, and only 2 studies reported calibration metrics, highlighting high risk of bias and the need for rigorous external validation before clinical deployment. Clinicians should remain aware of these developments while recognizing that current AI tools are decision support aids, not replacements for clinical judgment, and that the standard of care for wound assessment continues to require skilled clinical evaluation. Consumer-grade wearable devices and dedicated rehabilitation monitoring platforms are increasingly integrated into postoperative THA care. Accelerometer-based activity monitors, including smartwatches and hip-worn sensors, provide objective daily step count data that correlates strongly with functional recovery milestones. Remote patient monitoring platforms that integrate wearable data with patient-reported outcome measures enable clinicians to identify patients deviating from expected recovery trajectories and intervene proactively. Inertial measurement unit systems attached to the thigh and shank provide gait kinematic data, including stride length, cadence, stance to swing ratio, and hip range of motion during walking, enabling objective gait quality assessment without laboratory-based motion capture. These systems have demonstrated validity coefficients exceeding 0.90 compared to gold standard motion analysis. However, significant barriers remain, including data standardization across devices, clinician training in data interpretation, patient compliance with device wear, and the absence of validated clinical decision algorithms that translate wearable data into specific treatment modifications. Robotic assisted total hip arthroplasty has gained substantial market penetration, with approximately 15 to 20% of primary TAs in the United States now performed with robotic assistance. While robotic platforms, including Mako, ROSA, and Vali systems, demonstrate improved component positioning accuracy with reduced outlier rates compared to conventional manual instrumentation, the implications for post-operative rehabilitation remain modest. Current evidence from meta-analysis of randomized controlled trials demonstrates no significant differences in patient-reported outcomes, functional recovery trajectories, or complication rates between robotic-assisted and conventional THA at 1 year or beyond. The primary rehabilitation relevant advantage is potentially improved soft tissue preservation through smaller incisions and more precise bone preparation, which may reduce early postoperative pain and speed up initial mobilization. But these differences are small, typically 0.5 to 1.0 points on a 10-point pain scale during the first 48 hours, and equalize within 2 to 4 weeks. Rehabilitation professionals should understand that robotic-assisted THA doesn't require modified rehabilitation protocols. The same evidence-based exercise progression, balance training, and return to activity guidelines apply regardless of surgical technology. We're now in Module 7, which addresses special populations including trauma, cognitive impairment, and return to activity. Let's start with the fundamental distinctions between trauma and elective THA. Rehabilitation approaches differ substantially between elective and trauma-related hip arthroplasty populations due to fundamental differences in patient characteristics, physiological stress, comorbidity burden, and recovery trajectories. Even after propensity matching for age, sex, and comorbidities, fracture patients have 2.5 times higher rates of major postoperative complications, 5.88% versus 2.34%, nearly 6 times higher in-hospital mortality, 1.82% versus 0.31%, and significantly longer hospital stays, 12.09 versus 7.80 days. Those are stark differences, and they necessitate distinct rehabilitation planning, prognostic counseling, and resource allocation for each population. Healthcare costs for trauma THA are substantially higher. Average cost per patient is $32,228 compared to $22,917 for elective THA, representing a 41% cost differential reflecting longer length of stay, higher complication rates, and greater rehabilitation resource use. Discharge patterns differ dramatically between populations. Trauma patients have home discharge rates of only 35.8% compared to 60.0% for elective patients, and their readmission rates within 72 hours are more than 3 times higher, 1.3% versus 0.4%. While both populations benefit from early mobilization within 24 hours postoperatively, trauma patients require more intensive, multidisciplinary support and modified expectations. Elective patients typically progress to stair climbing by postoperative day 4, whereas trauma patients require individualized progression based on cognitive status, pain tolerance, and medical stability. Trauma patients demonstrate significantly slower functional recovery. While elective patients achieve most milestones within 1 to 3 months, trauma patients may require 4 to 11 months, with gait and balance recovery taking approximately 9 months and lower extremity function requiring up to 11 months. Specific comorbidity profiles are more prevalent in trauma populations. Dementia or cognitive impairment affects 40 to 45% of hip fracture patients compared to 3 to 5% of elective THA candidates, significantly impacting rehabilitation capacity and requiring modified communication and learning strategies. Anemia with hemoglobin less than 10 grams per deciliter affects 30 to 40% of trauma patients, compared to fewer than 5% of elective patients, and necessitates activity titration based on fatigue and cardiac response. Secondary fracture risk represents a critical long-term concern in the trauma population. 10 to 20% of hip fracture survivors experience a subsequent hip fracture within 5 years. This elevated risk necessitates systematic secondary fracture prevention programs, including bone density assessment within 3 months of fracture healing, calcium and vitamin D supplementation with elemental calcium 1,200 milligrams daily and vitamin D 1,000 international units daily, and bisphosphonate therapy for patients with osteoporosis with T-score less than -2.5 or osteopenia with additional risk factors. Falls prevention programs using the 50-hour minimum effective dose framework discussed in Module 5 are particularly important. Multidisciplinary rehabilitation supervised by a geriatrician produces the strongest evidence for improved outcomes in the trauma population. The Cochrane Review by Handal and colleagues in 2021 demonstrated that multidisciplinary rehabilitation reduces poor outcomes, defined as death or deterioration in residential status, by 12% at 6 to 12 months, risk ratio 0.88, confidence interval 0.80 to 0.98, with a number needed to treat of 25. Phased rehabilitation management incorporating structured exercise prescription and progressive resistance training significantly improves Harris hip scores, reduces deep vein thrombosis rates 2.7% versus 14.1%, and enhances activities of daily living compared to conventional rehabilitation approaches. VTE prophylaxis strategies must account for the higher baseline thrombotic risk in trauma patients. While low-dose aspirin may suffice for low-risk elective patients, as we discussed in Module 2, trauma patients, particularly those discharged to institutional care, benefit from anticoagulant prophylaxis, which reduces VTE risk by nearly half compared to aspirin, 2.3% versus 4.4%, odds ratio 0.52. Let's turn to anemia management and transfusion thresholds in trauma THA patients. Anemia affects 30 to 40% of hip fracture patients at presentation and represents a significant modifiable factor influencing rehabilitation capacity and functional recovery. Preoperative hemoglobin below 10 grams per deciliter is associated with reduced exercise tolerance, increased fatigue, impaired cognitive function, and higher rates of postoperative delirium, all of which directly compromise rehabilitation participation. Contemporary transfusion practice follows restrictive thresholds. The FOCUS trial established that a liberal transfusion strategy with a hemoglobin trigger of 10 grams per deciliter offers no functional advantage over a restrictive strategy with a hemoglobin trigger of 8 grams per deciliter or symptomatic anemia in hip fracture patients with equivalent 60-day mortality, functional independence, and walking ability. That said, clinical judgment should prevail for individual patients. Those with symptomatic anemia, including tachycardia, orthostatic hypotension, exertional dyspnea, or chest pain at hemoglobin levels above 8 grams per deciliter warrant transfusion, regardless of the absolute hemoglobin value. Iron supplementation, either oral ferrous sulfate, 325 milligrams twice daily, or intravenous ferric carboxymaltose 750 milligrams for patients with malabsorption or intolerance, should be initiated for all trauma THA patients with hemoglobin below 12 grams per deciliter and serum ferritin below 100 nanograms per milliliter, as iron deficiency without overt anemia still impairs exercise capacity and recovery. Erythropoietin-stimulating agents are generally not recommended for acute hip fracture management due to delayed onset of action of 2 to 4 weeks and thrombotic risk, but may be considered for patients with chronic kidney disease and persistent anemia during the rehabilitation phase. Now let's examine what I'd call the rehabilitation paradox of cognitive impairment. Over 40% of hip fracture patients have dementia or cognitive impairment, a prevalence far exceeding that in elective THA populations. Cognitive impairment creates a paradoxical barrier to recovery. Patients with dementia have 41% higher odds of delayed discharge, yet receive significantly worse care, with only 35% receiving rehabilitation services compared to 64% of cognitively intact patients, less than 0.0001. This disparity represents a critical equity issue because the evidence demonstrates that higher rehabilitation intensity improves outcomes even in cognitively impaired patients. Living situation also substantially influences discharge patterns. Those living alone before fracture have 9.22-fold higher odds of discharge to a nursing home, confidence interval 6.14 to 15.38. A nationwide Japanese study of 43,206 hip fracture patients with dementia provided some of the most compelling evidence for intensive rehabilitation. Each additional day of delay in starting rehabilitation was associated with a 0.38 point lower Barthel index at discharge, confidence interval 0.21 to 0.54. Rehabilitation provided more than 6 days per week improved the Barthel index by 9.16 points, confidence interval 7.34 to 10.97 compared to 3 days or fewer per week. Daily rehabilitation volume of 60 minutes or more improved the Barthel index by 6.60 points, confidence interval 5.63 to 7.57 compared to shorter sessions. Those dose-response relationships are clinically meaningful and argue strongly against the common practice of reducing rehabilitation intensity for cognitively impaired patients. Structured interventions can bridge the discharge location gap. Pre-discharge home visits by occupational therapists and nurses reduce 30-day readmission risk by 12.9-fold, confidence interval 2.1 to 79.3, in hip fracture populations. Orthogeriatric home visits initiated within 1 month post-discharge further reduce both 30-day readmission rates by 22.7%, p equals 0.026, and mortality by 28.3%, p equals 0.018. An international expert consensus process identified 59 core statements for delivering physical rehabilitation to people with advanced dementia after hip fracture, emphasizing whole person, person-centered approaches, highly skilled professionals with dementia-specific communication strategies, environmental adaptations including repetition and routine, simplified instructions, reduced distractions, caregiver involvement in therapy sessions, and proactive pain management before therapy sessions. Multi-component non-pharmacologic delirium prevention strategies reduce delirium incidence by 53%, odds ratio 0.47, confidence interval 0.38 to 0.58, and proactive geriatric consultation can reduce delirium from 50% to 28%. The bottom line, rehabilitation intensity protocols shouldn't be reduced for cognitively impaired patients. Rather, the methods for delivering intensive protocols must be adapted through enhanced caregiver involvement, simplified queuing systems, environmental optimization, and increased professional supervision. Let's now discuss return to activity, sport, and work milestones. Functional recovery after THA follows a predictable trajectory. Sato and colleagues in 2023 demonstrated that patient-reported outcome measures show the greatest proportional recovery within the first month post-operatively, with each improving by at least one minimal clinically important difference, while objective measures such as daily steps and flights of stairs take 3 months and 1 year, respectively, to reach 1 MCID of improvement. That gap between subjective and objective recovery highlights the importance of ongoing monitoring and exercise encouragement well beyond the point at which patients report feeling improved. Long-term physical activity counseling should be incorporated as a standard component of THA follow-up care, as population-level data consistently demonstrate that fewer than half of THA patients meet health-enhancing physical activity guidelines at 1 year post-operatively. Sedentary time remains high even among patients who report subjective recovery satisfaction. Structured activity counseling at routine follow-up visits, including specific exercise prescriptions for aerobic activity at 150 minutes per week of moderate intensity activity, resistance training at 2 to 3 sessions per week targeting lower extremity and core musculature, and balance work incorporated into daily routines produces significantly higher physical activity levels compared to general advice to remain active. Wearable activity monitors with goal-setting features increase daily step counts by 1,500 to 2,500 steps compared to control conditions. Regarding return to sport, an umbrella review by Sowers and colleagues in 2023 found that 82% of patients returned to sport at a mean time of 6 months, with a range of 4 to 7 months, with the best prognostic indicator being previous experience in the sport. Lin and colleagues in 2025 reported that 73.2% of preoperative athletes returned to sport, and 23.3% of previously inactive patients took up sports post-operatively, with low-impact sports having significantly higher return rates than high-impact sports, 72.4% versus 50.0%, but less than 0.001. And here's an encouraging finding. High physical activity, including jogging several times weekly, doesn't increase revision risk within 2 years, and revision-free survival rates are actually better among highly active patients, suggesting that activity promotes rather than compromises implant longevity. Driving resumption represents a key functional milestone with medico-legal implications. Driving typically resumes between 2 and 8 weeks postoperatively, with a mean of 3.7 to 4.4 weeks, with 88% returning within 6 weeks and 98.2% within 12 weeks. Key predictors of delayed return include right-sided procedures, persistent pain, limited hip range of motion, and discharge to a rehabilitation facility. Return to work occurs at a mean of 10 to 14 weeks, with 69% of patients returning and 78% resuming original work duties without restrictions by 1 year. Psychosocial working conditions, including decision authority, supervisor and coworker support, and social community at work, play important roles. Workplace modifications should be individualized. Sedentary desk jobs may allow return within 4 to 6 weeks. Standing or walking duties may require 8 to 12 weeks. Regular walking distances exceeding 2 to 3 kilometers or frequent stair climbing may require 3 to 4 months. Fewer than half of THA patients meet physical activity guidelines at 1 year, which again drives home the need for ongoing activity counseling as a standard component of long-term follow-up. We're now in Module 8, which presents case studies integrating principles from all preceding modules. Let's begin with Case Study 1, a straightforward elective THA with a self-directed recovery pathway. Mr. Robert Chen is a 62-year-old male retired high school basketball coach presenting for right total hip arthroplasty via the direct anterior approach for end-stage osteoarthritis. His body mass index is 27.4 kilograms per meter squared. Medical history includes well-controlled hypertension on lisinopril 10 milligrams daily and mild hyperlipidemia managed with atorvastatin 20 milligrams daily. He's a non-smoker, lives with his wife in a single-story home, and independently performs all activities of daily living. Preoperative assessment reveals a Harris hip score of 42, WOMAC pain subscale of 14 out of 20, preoperative timed up and go of 8.2 seconds, and a risk assessment and prediction tool score of 11 out of 12. He expresses strong motivation to return to recreational golf, hiking, and coaching summer basketball camps. Mr. Chen's RAPT score of 11 places him firmly in the low-risk category, predicting home discharge with greater than 90% accuracy and identifying him as an appropriate candidate for self-directed rehabilitation. His preoperative tug of 8.2 seconds falls below the 10-second threshold, further supporting expectations for independent ambulation at 6 months. He's counseled regarding the ERAS pathway, including expectations for same-day mobilization, multimodal analgesia with opioid-sparing protocols, and no routine hip precautions given the anterior surgical approach. VTE prophylaxis is initiated with aspirin 81 milligrams twice daily for 28 days, appropriate for this low-risk elective patient without VTE risk factors. Under the ERAS protocol, Mr. Chen ambulates with bilateral crutches 4 hours postoperatively, achieves independent transfer by postoperative day 1, and is discharged home the same day with a web-based self-directed rehabilitation program. His exercise program follows the phase-specific protocols outlined in Module 5, isometric quadriceps and gluteal sets, ankle pumps, heel slides, and gait training during week 1, progressing to standing hip exercises, mini squats, step-ups, and resistance band training during weeks 2 through 6. Let's walk through his exercise progression. During the first postoperative week, he performs quadriceps and gluteal isometric sets 5 times daily with 3 sets of 10 to 15 repetitions, hip abduction exercises 3 times daily, and gait training with bilateral crutches 3 times daily for 10 to 15 minutes. By week 2, he advances to active-assisted hip flexion exercises, mini squats within pain-free range, straight leg raises with ankle weights, and gait training with a single tip cane. By week 4, he progresses to resistance band exercises, forward step-ups on a 4-inch step with handrail support, and bridging exercises. At week 6, his tele-rehab visit demonstrates pain levels of 2 to 3 out of 10 during exercise, 90 degrees hip flexion, and 20-second single leg stance. Progressive resistance training is initiated at 8 weeks, targeting 60% one repetition maximum, progressing by 10% every 2 weeks. By 12 weeks, he performs leg press at 85% 1RM, with 4 sets of 5 repetitions 3 times weekly, achieving 43 kilograms greater strength compared to preoperative baseline. At 6 weeks postoperatively, Mr. Chen's daily step count has increased to 6,200, consistent with average benchmarks. He ambulates without assistive devices and reports HUS JR score improvement exceeding the minimal clinically important difference. He returns to driving at 3 weeks and to golf with a half swing at 6 weeks, progressing to full play by 10 weeks. At 3 months, Harris' hip score is 91. He resumes hiking, and at 6 months, he returns to coaching basketball camps without restriction. His 1-year Harris hip score is 95. This case illustrates the successful application of risk stratification tools to guide self-directed rehabilitation, the effectiveness of ARIS-based same-day discharge, systematic phase-specific exercise progression, and evidence-based return to sport timelines. Let's now look at Case Study 2, a complex elective THA involving comorbidity management and formal rehabilitation. Mrs. Patricia Owens is a 74-year-old female presenting for left total hip arthroplasty via the posterolateral approach for severe osteoarthritis. Her body mass index is 34.2 kilograms per meter squared. Medical history includes insulin-dependent type 2 diabetes mellitus, with a preoperative HbA1c of 7.8%, hypertension, mild chronic kidney disease with eGFR of 52, hypothyroidism, and a history of depression managed with sertraline 50 milligrams daily. She lives alone in a 2-story home with a bedroom upstairs and has a daughter who can provide assistance for the first 2 weeks post-operatively. Preoperative assessment reveals a Harris hip score of 38, WOMAC total score of 62, preoperative tug of 14.6 seconds, and a RAPT score of 6 out of 12. SF12 physical component score is 28.3. Mrs. Owens presents multiple risk factors. Her RAPT score of 6 places her in the high-risk category, predicting the need for formal, supervised rehabilitation and potential non-home discharge. The preoperative tug of 14.6 seconds exceeds the 10.5-second threshold associated with delayed recovery. Her HbA1c of 7.8% falls within the ADA recommended threshold of 8% or below, but above the optimal THA threshold of 7%. Metformin is held on the day of surgery, and her insulin regimen is converted to a basal bolus perioperative protocol with glucose monitoring every 4 to 6 hours, targeting 100 to 180 milligrams per deciliter. Given the posterior surgical approach, modified hip precautions are implemented restricting only the combined position of flexion, adduction, and internal rotation. VTE prophylaxis is initiated with apixaban rather than aspirin, given her obesity, advanced age, insulin-dependent diabetes, and anticipated discharge to a supervised rehabilitation setting where reduced mobility increases thrombotic risk. Negative pressure wound therapy is applied given her elevated wound complication risk from obesity and diabetes. She mobilizes on postoperative day 1 with physical therapy, achieving supervised ambulation of 25 meters with a rolling walker. Nursing interventions include predictive nursing with thorough risk assessment, pain management using the multimodal ARAS protocol, and DVT surveillance. The discharge planning team determines using the plan and AMPAC 6-clicks dual assessment that Mrs. Owens is appropriate for discharge home with outpatient physical therapy rather than skilled nursing facility placement, given her daughter's availability and the evidence that SNF discharge is associated with higher readmission rates. Formal outpatient physical therapy is prescribed 3 times weekly for 6 weeks. Occupational therapy assessed and modified her home environment for discharge. A temporary first-floor bedroom setup, elevated toilet seat with armrest, shower chair with back support, long-handled reacher and sock aid, and upper extremity strengthening given anticipated walker dependence. ADL retraining focused on dressing strategies, bathing safety, and modified kitchen tasks. Mrs. Owens is discharged home on postoperative day 2. Perioperative blood glucose remained between 110 and 174 milligrams per deciliter. At 6 weeks, she ambulates with a single-tip cane, tug has improved to 11.8 seconds, and Harris hip score is 68. She continues outpatient PT through 12 weeks with progressive resistance training targeting hip abductors and extensors. During weeks 6 through 12, PT focuses on maximal strength training progressing from 60% to 85 to 90% 1RM, with leg press improving from 40 kilograms at week 6 to 83 kilograms by week 12. At 3 months, she discontinues the cane. Tug is 10.1 seconds, and Harris hip score reaches 82. At 6 months, she navigates stairs independently, performs all ADLs without restriction, and HbA1c has improved to 7.2%. This case illustrates the importance of comorbidity-specific perioperative optimization, RAPT-guided rehabilitation pathway selection, risk-stratified VTE prophylaxis, the value of formal PT for functionally complex patients, and the central role of nursing and OT interventions. This concludes our case studies and the course total hip arthroplasty, evidence-based update. Thank you for your attention throughout this continuing education program. We will now review the exam questions to solidify your understanding of the key concepts covered in this course on total hip arthroplasty. For each question, I will read the question aloud, identify the correct answer, and then provide a brief rationale explaining why that answer is correct. Let's get started. Question 1. According to the network meta-analysis by MCISA and colleagues, which individual prehabilitation component was identified as the single most effective for reducing postoperative complications following total hip arthroplasty? The correct answer is C, exercise. Rationale. The MAC-ISAIC network meta-analysis was a landmark study that pooled data from 1086 randomized controlled trials involving over 15,000 participants. Among all individual prehabilitation components examined, exercise emerged as the single most effective intervention, producing an odds ratio of 0.50, meaning it cut the odds of postoperative complications roughly in half. Nutritional optimization ranked second with an odds ratio of 0.62. While psychosocial support and technology-assisted programs have value within multimodal prehabilitation, neither demonstrated the same magnitude of independent effect as structured exercise. This finding reinforces the central role of physical activity in preparing patients physiologically for the demands of surgery and early recovery. Question 2. Which of the following is a recommended component of preoperative carbohydrate loading within an enhanced recovery after surgery protocol for total hip arthroplasty? The correct answer is A, administration of a 12.5% maltodextrin solution, approximately 400 milliliters, 2 hours preoperatively. Rationale. One of the foundational elements of ERAS protocols is the elimination of prolonged preoperative fasting. Traditional practice required patients to fast from midnight, but current evidence shows this is unnecessary and potentially harmful. Preoperative carbohydrate loading with a clear, carbohydrate-rich beverage, typically a 12.5% maltodextrin solution given about 2 hours before surgery, helps maintain hepatic glycogen stores and significantly reduces postoperative insulin resistance. This metabolic preparation supports better glucose regulation after surgery, reduces patient discomfort and anxiety, and contributes to faster functional recovery. The other options, including overnight fasting, high-protein meals, or intravenous dextrose, do not reflect current ERAS recommendations. Question 3. According to the evidence presented, which venous thromboembolism prophylaxis strategy is recommended for patients discharged to inpatient rehabilitation or skilled nursing facilities after total hip arthroplasty? The correct answer is D, anticoagulant prophylaxis regardless of baseline risk profile. Rationale. This question highlights an important nuance in VTE prevention that clinicians must understand. While aspirin has gained acceptance as a prophylactic agent for many standard-risk THA patients discharged home, the evidence from Ho and colleagues in 2025 demonstrated that patients discharged to inpatient rehabilitation or skilled nursing facilities face a fundamentally different risk environment. In these institutional settings, anticoagulants yielded nearly half the VTE risk compared to aspirin alone, with rates of 2.3% versus 4.4%. The institutional setting itself confers additional thrombotic risk due to factors such as reduced mobility, shared care environments, and the generally higher acuity of patients requiring that level of care. Therefore, anticoagulant prophylaxis is recommended for this population regardless of their baseline risk profile. Question 4. A patient has a preoperative risk assessment and prediction tool score of 6 out of 12 and a timed up and go time of 13.8 seconds. Based on these results, which rehabilitation pathway is most appropriate? The correct answer is D, formal supervised rehabilitation. Rationale. This question tests your ability to interpret two commonly used clinical prediction tools and apply them to discharge planning. The Risk Assessment and Prediction Tool, or RAPT, uses a 12-point scale to stratify patients by their likelihood of needing extended rehabilitation. A score below 7 indicates high risk, meaning the patient is likely to require formal, supervised rehabilitation rather than self-directed or minimally supported recovery. The Timed Up and Go test provides a complementary functional assessment. A time exceeding 10.5 seconds predicts delayed recovery and the need for structured physical therapy. In this scenario, both instruments converge on the same clinical conclusion. A RAP score of 6 and a timed up and go time of 13.8 seconds both exceed their respective risk thresholds, clearly indicating that this patient requires formal supervised rehabilitation to optimize outcomes. Question 5. During the late recovery phase, weeks 6 through 12, of total hip arthroplasty rehabilitation, what is the recommended target intensity range for maximal strength training protocols? The correct answer is A, 85 to 90% of maximal capacity, structured as 4 sets of 5 repetitions performed 3 times weekly. Rationale. This question addresses the growing body of evidence supporting higher intensity strength training during the later phases of THA recovery. For patients who have progressed appropriately and are capable of tolerating greater loads, maximal strength training protocols at 85 to 90% of maximal capacity produce substantially greater strength gains than conventional physiotherapy approaches. The structure of 4 sets of 5 repetitions performed 3 times weekly reflects established strength training principles that balance sufficient training volume with adequate recovery between sessions. The other options either represent intensities too low to drive meaningful strength adaptation at this recovery stage, or intensities that would be excessive and potentially unsafe. This evidence challenges the traditionally conservative approach to post-DHA strengthening and supports more aggressive loading in appropriate candidates. Question 6. Which of the following findings regarding telerehabilitation outcomes after total hip arthroplasty is supported by the systematic review evidence presented in the course? The correct answer is C. Telerehabilitation demonstrated superior outcomes in physical functional tests compared to face-to-face rehabilitation. Rationale. This finding from the systematic review by Wang and colleagues in 2023 may seem counterintuitive at first. The review found no significant differences between telerehabilitation and face-to-face rehabilitation for pain, range of motion, or patient satisfaction. However, telerehabilitation actually demonstrated superior outcomes specifically in physical functional tests, with a standardized mean difference of -0.54. The proposed explanation for this unexpected advantage is that the structured accountability inherent in remote monitoring may promote more consistent exercise adherence. When patients know their activity and progress are being tracked remotely, they may be more motivated to complete their prescribed exercises consistently. This finding is clinically significant because it supports telerehabilitation not merely as an equivalent alternative, but potentially as a superior delivery model for certain functional outcomes. Question 7. Compared to elective total hip arthroplasty patients, which of the following best describes outcomes for trauma-related or hip fracture THA patients, even after propensity matching for age, sex, and comorbidities? The correct answer is B. 2.5 times higher rates of major postoperative complications and nearly 6 times higher in-hospital mortality. Rationale. This question underscores the critical distinction between elective and trauma-related THA populations. Even when researchers use propensity matching to control for confounding variables such as age, sex, and comorbidity burden, fracture patients still demonstrate dramatically worse outcomes. Specifically, they experience 2.5 times higher rates of major postoperative complications at 5.88% versus 2.34%, nearly 6 times higher in hospital mortality at 1.82% versus 0.31%, and significantly longer hospital stays averaging over 12 days compared to under 8 days. These differences persist because trauma-related THA involves acute physiological stress, inflammatory cascade activation, and the absence of the preoperative optimization window that elective patients benefit from. Clinicians must recognize these fundamentally different risk profiles when planning care for fracture patients undergoing arthroplasty. Question 8. According to the meta-analysis by Zhang and colleagues, what was the effect of enhanced recovery after surgery implementation on hospital length of stay following total hip arthroplasty? The correct answer is D, reduction of 2.65 days with high statistical significance. Rationale. The Zhang meta-analysis represents one of the largest systematic reviews of EROS outcomes, encompassing 407 studies and nearly 77,000 patients. The finding that EROS implementation reduces hospital length of stay by a weighted mean difference of 2.65 days is both statistically significant and clinically meaningful. Importantly, this reduction in length of stay was not achieved at the expense of patient safety. The analysis confirmed that EROS protocols did not increase complication rates or hospital readmissions. This is a critical point because one of the common concerns with accelerated discharge pathways is that patients may be sent home prematurely. The evidence clearly demonstrates that the comprehensive, multimodal approach of ERAS protocols allows for genuinely faster recovery, not simply earlier discharge. Question 9. What is the recommended pain threshold during progressive exercise in the early recovery phase, weeks 1 through 6, of total hip arthroplasty rehabilitation? The correct answer is B. Pain during exercise should remain below 35 millimeters on a 0 to 100 millimeter visual analog scale. Rationale. Establishing a clear, evidence-based pain threshold is essential for safe and effective exercise progression after THA. The recommendation that pain during exercise should remain below 35 millimeters on a 100 millimeter visual analog scale provides clinicians with a concrete, measurable guideline for determining whether exercise intensity is appropriate. Additionally, the evidence indicates that mild pain at rest, in the range of 1 to 18 millimeters on the visual analog scale, is acceptable and typically decreases over time even as load progression continues. This finding is particularly important because it empowers clinicians to progress exercise intensity with confidence rather than reflexively reducing activity at the first sign of discomfort. At the same time, it establishes a clear upper boundary that protects patient safety and helps differentiate expected post-exercise soreness from potentially harmful overloading. Question 10. In a nationwide Japanese study of hip fracture patients with dementia, what was the effect of providing rehabilitation more than 6 days per week compared to 3 days or fewer per week? The correct answer is C. Improvement in the Barthel Index by 9.16 points. Rationale. This nationwide study of over 43,000 hip fracture patients with dementia provides powerful evidence that rehabilitation intensity matters, even in cognitively impaired populations. Patients who received rehabilitation more than 6 days per week improved their Barthel Index scores by 9.16 points compared to those receiving 3 days or fewer per week. The Barthel Index measures functional independence and activities of daily living, so a 9-point improvement represents a clinically meaningful gain in a patient's ability to perform basic self-care tasks. This finding is particularly significant because there has historically been a tendency to provide less intensive rehabilitation to patients with dementia based on the assumption that cognitive impairment limits their capacity to benefit. This study directly challenges that assumption and supports providing high-frequency rehabilitation to maximize functional outcomes in this vulnerable population. That concludes our review of all 10 exam questions. Remember, the key themes across these questions include the importance of structured prehabilitation and exercise, the role of ERAS protocols in improving perioperative outcomes, evidence-based approaches to VTE prophylaxis and pain management, the value of validated screening tools for discharge planning, and the growing evidence supporting both higher-intensity rehabilitation protocols and tele-rehabilitation delivery models. Good luck on your exam.